Hello friends, welcome again to my part 2 of how to get optimal images in ultrasound. Mu part 1 twayogera ku patient preparation, twayogedde ku taking patient history, explaining the procedure of the patient positioning, giving proper instruction to the patient, and today we want to start on point number 7, that is reducing patient movement. Now, let us start with machine adjustment. Now, because you've totally taken the proper history of the patient and you have totally understood the patient needs, you know what you're going to do, you prepared your patient well, we now need to adjust our machine depending on the organ of interest that we are going to do, but also depending on what we want to see. We need to adjust our focus, we need to adjust our TGC to make sure we have optimal visualization of the images. Remember, incorrect adjustment of our TGC, incorrect adjustment of our depth, incorrect adjustment of our focus may cause unnecessary increase or decrease in echogenicity that may mimic pathology or that may confuse interpretation. Because, for example, you're looking at the liver, but then maybe your focus is way below to the level of the kidneys. We are talking about right kidney. Sometimes the right kidney may appear as if it has increased the echogenicity compared to the liver, and that may create pseudopathology, pathology that does not exist. So, chirungi, we adjust those things actually before we start, because you know the organ of interest. And as a skill, we must learn to keep adjusting those three depending on the different organ that we are scanning. Some of us work with the same focus all through. We need to keep adjusting our focus, our depth. The image, number one rule of sonography is that the image must occupy at least 3/4 of the screen. That means we are going to keep zooming in or increasing or reducing depth to make sure that our image is taking at least 3/4 of our screen. So that is important to adjust your machine. Brightness, contrast, we don't normally touch those, but at least you can use your TGC to optimize, to make sure you have the best image possible. Even if you're doing color Doppler, you can increase or adjust your color gains to make sure you don't have aliasing, you don't have what we call bleeding, but you just have optimal setting to give you the right color flow. Because sometimes if you over reduce the scale, sometimes we cause unnecessary flow. We even pick small veins, but also if you over increase the scale, sometimes we lose flow on the vein that we are interested in. So we must adjust our settings to make sure we capture needed images. Then number 8 is you reduce patient movement. Sometimes when the reason we are having blurry sonography images simply because we don't take images at rest. For example, you're talking to the patient and you're enjoying your kabozi, you're enjoying your jazz, and then you're capturing images of the liver. Before you know it, the patient, you take images in between the patient's breath. So the images are blurred, they're not sharp. And that can cause us to miss pathology or to create pathology to the person that is going to look at the images that we captured. So it is important that while you're taking images, you instruct the patient to actually to hold their movements or to hold their breath if possible. People that are doing Doppler studies, sometimes you're looking at the carotid, you're looking at common carotid, and then maybe the patient is talking. The patient is talking or is shaking their head. So in that, you end up capturing images that are not good. So we need to know when to ask the patient to hold still as we capture those images to avoid having images with movement blur. Number 9 is For organs, for all organs, we need to take the organs uh, in the appreciable recognized standards. For example, for all organs, we are supposed to have them in the sagittal view and also in the transverse view. For any organ, actually, the rule is that you must have a sagittal view. Sagittal view means you must give us the longest length of that organ. Now, like the kidney may be here, the right kidney may be here. By sagittal in CT, most of the time we are going to do, sagittal, left and right. But to the organ, we want the sagittal view of the organ. So sometimes the sagittal view of the organ is actual oblique view to the patient's body alignment. So we want the sagittal view of that organ and then the transverse view of that organ. We use the sagittal view to measure the length and height, and we use the transverse view to measure the width. And as a rule, all organs must be measured in the 3 dimensions because we are looking at volume. We no longer look at most of the organs. We no longer look at, apart from maybe the liver, but most of the organs we want to look at the 3 dimension to get the volume, composite volume. So it is good that we have the sagittal view of every organ. And for every organ, after giving us the sagittal view, give us the left sagittal, right sagittal, and mid. Mid is when you're in the middle. And that's normally where we take the measurements from. So in the transverse view, give us the transverse inferior, superior, mid, and superior. That helps whoever is reading your images to have, for example, a right kidney. You give us right kidney mid, you say right kidney sagittal mid, then medial and lateral. Okay. If it is the sagittal view of the urinary bladder, give us sagittal view right and left, because for it is in the middle, it doesn't have mid or lateral. But these other organs like the kidneys, you can give us mid and lateral. Then when you go to the transverse of a kidney, give us transverse superior, transverse inferior. That gives your radiologist or your physician or your doctor a chance to look at what you're looking at, or the entire organ. That even if you missed something, you're going to be able to go and they are able actually to pick it out. Because at the end of the day, we are looking at a patient getting the best possible report from our imaging. It's not who is wrong, who is right. But also more confidence that when you say the scan is normal, the doctor is really going to say the scan is normal. Okay. The other thing that we can use to optimize our images. So imagine all the organs, you pick those views. So that means your doctor is going to be competent that actually when you say normal, it's normal, or when you call pathology, it's pathology, because they can also see it themselves. Number 10, for optimization of ultrasound images is measurements. I talked about measurements. We need to measure the organs, and this must be consistent with all of us. We need to measure the organs. We need to know where to put the calipers. We need to know which organs or which structures we measure outer to outer or inner to inner, to make sure that if I measure something in a CT, you should have the same measurements in scan. Or if I do scan today and the liver and the mass is 2 centimeters and another scan is done 6 months later, we should be able to place our calipers at the same position, because for some of these masses, changes inside they either call for biopsy or no biopsy. So if you just put your calipers in the wrong position and that caused the increase or enlargement, really the same mass but wrongly measured by 2 sonographers, one is going to force the radiologist to go in and biopsy a mass that is not to be biopsied, causing an extra cost to the patient and pain. but literally for something that is not supposed to be done like that, only because one sonographer did not follow the right procedure. So we need to measure our images in the right procedure and manner. This we can learn from senior people, or we can read and see where they place calipers when they are measuring this and that. So we are supposed to use the sagittal view of every organ to measure. For example, if this is the sagittal view of the kidneys, we are going to measure length and height. And then when we get the lateral view, which is normally like what? No, like this. Then we measure the width. So in sagittal we measure length and height. Then in transverse we measure the width, and then automatically the machine will compute volume and document volume if they want it, or document the 3 dimensions if your department, the protocol asks you for those 3. And then transverse. And then lastly, we are supposed to put color flow for every organ. Now it is fortunate enough that most of the departments in Uganda are having machines that are having color flow. So we are supposed to put color flow. Color flow helps us to know if there is perfusion. Okay, let me stop this here and then I'll come with part 3. Thank you so much for watching. Please share this with all the junior sonographers, with everyone in your department, and feel free to come in my comment and add a point that you feel I've missed, or correct me where you feel I'm wrong. This is only my observation. This is only my simple. I'm not a professor, just trying to help a friend better our profession.